on putting the personalised care desk spec into action. If we could just have the slides up as well, please. And next slide, please. So just a reminder about the sessions that we run every month. So the purpose is for us to support PCNs to successfully embed the personalised care roles of social prescribing link workers, health and wellbeing coaches and care coordinators to effectively tackle health inequalities and support primary care, and also to build a network of those that employ or are working to embed the personalised care roles in their work and facilitate a community of practice across London. So I'm here now with Portfolio GP in North West London and share the role of PCN advisor for social prescribing personalised care and health inequalities with Leanna Martin, who's also here today. And we also have Jenny Brooks, who many of you will be familiar with, and she is our health inequalities project manager in the social prescribing team at the Healthy London Partnership. So very warm welcome to all of you. Next slide, please. And just a reminder of the other support that is available as well. So the monthly Pan London Connect and Share sessions, if you haven't been able to attend the ones in the past, you can also access recordings, and we'll be sharing the links in the chat, but also in the communication that goes out later on should you wish to access these recordings. We also offer one-to-one support every Wednesday with PCN. So it could be a manager, a CD, or anyone really who's working within a PCN setting to embed 3 roles. So we're available to book in for 30-minute slots, just for you to be able to talk through any issues that you might be facing, or just to think through some of your strategy. We also have a WhatsApp group for you to join, where you can connect with each other in a more informal setting. And again, we'll share the link to join that as well. And then on top of that, we have monthly communication, so through a newsletter, and we also communicate up to NHS England any of the issues that you bring to us in any of the sessions, and are currently working on co-producing a PCN toolkit and FAQ guide. And some of you may have been at the feedback session that we ran a couple of weeks ago around that. Next slide, please. So today's session will be focusing on the proactive outreach social prescribing spec, and I'm really excited.
Do you want to open on emo check instead?
Later on, it's fine. Yeah.
Sorry, can I just remind everyone to put themselves on mute, please? Thank you.
Trying to make it nice. I'm trying now. I'm just struggle.
I just put everyone on mute here now. So much fun. You'll need to unmute yourself, Hina.
Sorry. So I'm really excited that we have Michelle Pilling with us today, who will be going through the spec from a national perspective and also sharing some examples of the work that she's seen happening across the country. We'll also be sharing an example of some work going on in London, and then we'll be breaking out into small groups to really be able to think about some of the areas of the spec and what we could be doing to implement that. So really providing you with that space to be able to speak with other colleagues and think about what you could be doing. Next slide, please. So where are we currently? So in the room, we have a mixture of PCN managers and leads, social prescribers, primary care and personalised care delivery leads. And when you signed up for the session, we asked you a couple of questions. One was, what stage is your PCN at in terms of setting up a proactive social prescribing service? Just over half of you said that you were at the beginning. About a quarter had started or were planning on looking at delivering the spec, or planning the actions required to deliver the spec. About 10% were at the middle stage or in development, and just under 10% were unsure. We also asked you the areas of support that you wanted and identified the top 5, and these were information and models, examples of case studies, good practice and ways of working, understanding the process and practical framework, clear expectations and requirements of the DES, and co-designing stakeholder engagement, partnership and support. Next slide, please. And just a reminder of what the key actions are from the spec. specifically around proactive social prescribing and community development. So there is a target by the 30th of September for PCNs to bring together BCSE, local authority and community co-design targeted programs to increase access for a specific cohort with unmet need that they've identified using a combination of lived experience, population health and inequality data, social prescribing data. Think about setting an evaluation framework, whether they need to recruit more or specialised link workers as needed according to their local needs and priorities. And then by the 1st of October to start delivering a targeted intervention, and then later on to implement a minimum data set once this launches, and then thinking about next year extending onto more groups. But Michelle will be speaking much more about this. So next slide, please. So it's my real pleasure to be introducing Michelle. Many of you will know her already. So Michelle Pilling is a senior lead for social prescribing at NHS England, having held previous senior leadership roles as deputy chair of a clinical commissioning group and the Northwest Social Prescribing Regional Learning Coordinator for NHS England. In her time as commissioner, she was responsible for the investment of 4.2 million into community commissioning of grassroots social prescribing activities. Her social prescribing journey started back in 2001, first as a link worker in the VCSE, as a charity manager through to strategic leadership roles in the NHS. She brings a broad perspective of social prescribing and the VCSE and health and care economy with extensive experience of co-production and personalised care. Very warm welcome to you, Michelle, and over to you.
Lovely, and thanks for that wonderful introduction, Hina, and lovely to be working with London colleagues. We're always grateful to the help and support, not just for link workers, but for the other personalised care roles as well. You're very much at the forefront, so it seems fitting that where we're looking to launch the Proactive Social Prescribing Service Specification, London are proactive as always at the front of it. So I've got a lot of slides which I'll need to move quite quickly through. I've deliberately included quite a number of slides which are for reference really, because there's quite a bit that I want to cover in not much time, so hopefully you've got resources that you can go back to. So if we can move to the first slide please, Jenny, and just a quick reminder, you'll all know this, so personalised care is a huge ambition in the long-term plan to make personalised care approaches business as usual by 2024. There was significant ambition around social prescribing and the link worker roles. We started off with an early ambition to get 1,000 link workers, which has grown to 4,500 link workers by 2024. If I could move to the next slide, please. So where we are so far, so as of April this year, we know that we have at least 2,527 link workers, 699 health and wellbeing coaches, 2,775 care coordinators. So we're absolutely bang on trajectory for those roles, but we know that there's much more to do. So even if you consider 4.5 link workers, roughly 1,400 PCNs, so we've always signalled from the start that a single link worker working to a PCN, average size PCN about 48,000, simply won't be enough unless we've got whole teams of link workers supporting this work and being supported by health and wellbeing coaches, care coordinators. It's not going to be sustainable or implement as well as intended. And our ambition, you know, I think if we were honest, if we've got 6,500 GP practices where link worker roles are really working well, I think practices are seeing, you know, that an even bigger ambition for these roles. So if we can move on to the next slide, of course, the other ambition was to have 900,000 referrals to social prescribing by 2024. We've already achieved that ambition, but again, we know that there's much more to do. We know that a lot of link workers were redeployed to support the pandemic, and that's where they've really shown their worth and demonstrated their value. But actually the roles working in a general practice clinical way, that wasn't the intention. where these roles really work well is where they are working in and alongside communities and working in a different non-clinical way. So it's almost that old adage, if you do what you've always done, you get what you always got. And it was really great to hear Simon Gregory from Health Education England today saying that he believes that these roles are the most transformational of anything that's happening in general practice at the moment. So there is something about working differently, which takes us to the, if we go to the next slide, we'll just do a quick recap. When we first introduced the roles, it was always the intention right from the beginning, it's been written in the DES all the way along, that there's a shared plan for social prescribing. So it's almost how you set off on this journey, how you start off. If it's a collaborative endeavour, particularly with your local voluntary sector, local authority, place-based arrangements and others, that will very much determine what you get out of this. You know, so that has been in there, that need to work collaboratively and think about what your shared plan for social prescribing is. So if we could move on to the next slide and just quickly look at the service spec and actually what's written within there. Next slide, please, Jenny. We'll have to be quick on the button with some of these slides because some of them do move along quite quickly. If we're able to move on to the next slide, the next slide is the proactive social prescribing. I think we've gone one too far. We might need to go back a bit. Yeah, obviously you've got sticky keys today, so it's jumped a couple of slides. It is the one before this. But there we go. So the proactive service specification, what's it asking for? So the first part is what really should already be in place, that there's a social prescribing service and that actually there's a shared plan for social prescribing and get into that social prescribing service. So really thinking about what's new, put in place a targeted programme to proactively offer and improve access to social prescribing to an identified cohort with unmet needs. Now, again, the good news is there is so much work already happening. We can look at this in two respects. You've almost got proactive case finding, which we will see many asks of you to do this around population health management, anticipatory care, health inequality, tackling neighbourhood inequality, service spec, core 20+5. So what's different about the case finding bit, and then more importantly, how do we make sure more people are accessing social prescribing? And probably you're thinking, why is that important? So if we just move on to the next slide, which is just really the high level guidance that we put out, you know, to support this specification. So these are, you'll note that it says you may wish to, so they're pointers along the way. So definitely use population health management as your approach to how you find these groups, but there is something more which we'll come on to. Absolutely got to be a collaborative endeavour. How will you know you've made a difference unless you set some targets around how access improved? As I've said, will a single link worker be enough to match your ambitions? Well, and there's nothing prescriptive here. And for most PCNs, we absolutely fully understand you will have to start small with this and probably piggyback on some existing work. You know, we're not expecting, you know, that all PCNs to be at the same level. It is a journey that we're on. So utilise additional funding, and we are about to launch later in the summer the minimum data set. That may be something that you want to use to evidence impact. If we can move on to the next slide. So I just want to quickly, we will move over some of these slides quite quickly. So thinking about how you identify different your target group. We know there's also an ask around anticipatory care and population health management. So who are your patients who are at highest risk of unwarranted health outcomes, and not just the sort of, right, you know, the people that you will typically find from risk stratification, who are the hidden groups, and that's where social prescribing particularly comes into its own. Who are the people you won't see in the data? You know, you could start simple with something like carers. If your link workers are working proactively out in community and they're working alongside education, they're working alongside faith sector, They're working in the food bank. You know, do you need to go much more than that? You will find all sorts of hidden need and risks within those groups of people. Are you working with job centres, Department of Work and Pension? So definitely something there. If we move on to the next slide, please. The tackling neighbourhood inequalities, again, very similar, and this work has already begun. So this shouldn't be work that's new to PCNs. This is work that's already started last year. PCN should already have thought about, you know, the learning disabilities, serious mental illness, ethnicity recording, and to have already identified a population experience inequalities in health provision and a plan to tackle its unmet needs. So building on that work, it may be that having done that early work, having identified a group of people, so what? You know, so once you've done that, what is the piece of work? And some of you will already be using social prescribing or the two other roles to support that, those so what conversations. What do you do next with that? So if we can move on to the next slide, please. The next two slides actually will go over quite quickly, Jenny, because these are resource slides. So if you want to think that through in a bit more detail, the tackling neighbourhood inequalities. So obviously the ask is to understand local health inequalities, where resources can be targeted to these populations, and most importantly, developing strategies. And you should have a lead person in post to be helping with that. That lead person might also want to be working on this proactive social prescribing as well, and how you bring the two together. So if we can move on to the next slide. And at the bottom of this slide is also, so these are some of the resources that can support you with the tackling neighbourhood inequalities, and similarly help support you with the proactive social prescribing. So obviously we've also got the core 25+ approach, and if we can move on to the next slide, we'll just explain this, how this may also help you to think about both your approach and the intervention. If we can move to the next slide, please, Jenny. So core 20+5, obviously it's in the operational guidance, it's an approach, and it's also aligned with COVID response. So again, we know link workers played a significant role in COVID. If we can move to the next slide, which will be familiar to all of you, I'm sure, about the core 20+5. So to see this probably a bit more clearly, typically practices will be able to identify their core 20 populations, and you'll be able to apply risk stratification and other things. But actually, to what extent are you identifying the plus community? The plus community being those people who aren't in your data, people who've got those additional barriers to access, who probably got the greatest health inequality. So the people who need really good health services the most, the ones who are least likely to find it. Your social prescribing link workers could be really helpful here, particularly working with inclusion health groups, if that is your target population. And then thinking about the 5 clinical areas. We know link workers are supporting amazing work around hypertension, in maternity. We've got some specialist workers. I've just heard on the last webinar I was on today about a practice where we're not suggesting that link workers should be supporting serious mental health illness, but actually they are supporting some of the broader needs. So we heard a wonderful example of a patient who had schizophrenia, and actually helping them to connect with peer support and support within their community has really unlocked both them as an individual, their support, and reduced their frequency of attendance at general practice. So there are so many ways that some of the ask that you're already being asked to do can help to support the implementation of the proactive social prescribing. So very quickly before I finish, I just wanted to give a few examples. If we could move to the next, so that was just really, again, what I wanted to share from this slide is that sort of the premise that we can't do it all immediately. So we absolutely fully expect that this is a journey that we and you are on, and that PCNs will be different points of that journey. But I think the more that we share the working together, the further we'll all go faster. So if we can move to the next slide. And I'm going to just move on from this one as well and go to some of the examples about actually what this might then start to look like. So if we think about proactive social prescribing as a number of things, and it can start with proactive case finding. So how do you proactively find people who aren't in your data, the people with probably the greatest barriers to access the services, where we can really do the most to address inequality, certainly access to services and health inequalities. How could you use a social prescribing worker to do more proactive outreach? Because this is what we're hearing is the transformation where link workers are enabled to work out with communities. We can't integrate services unless we're working alongside with them. We see that's a real value of link workers, and great examples in London. You know, you feature regularly on our webinars, and we had a recent example around knife crime, for instance. For a lot of places in the country that's not going to be an issue, but it's a particular need in some parts of London. So, you know, social prescribing to target some of those communities, identify the hidden needs, and actually can you start to proactively capture different types of data from the work you're doing with communities and really see the difference that interventions, for instance, with your local gardening groups, your green social prescribing, work with the faith-based sector, with arts and culture, with all the great work you're doing around social legal welfare. We know that the financial distress is growing. It's not going to go away anytime soon. We know housing's a big issue in London. How do you know the difference that those interventions are making? So last couple of slides, and I can leave these for information, are just some examples. So we know that you may want to have an identified cohorts and find that the need is such that you want to recruit to more specialist roles. We know that children and young people are a particular focus in London, and for good reason. If we're really going to address inequality, we've got to start with early years, and there's some great examples, whether it's GP federated models, whether it's voluntary sector model, local authority, particularly where the hosted arrangements works really, really well. If we can move on to the next slide. Examples of working with particular communities and respecting that those communities will have specific needs. If we move on to the next slide, we've just tried to present you know, the different elements of proactive social prescribing. So it starts with stakeholder engagement and lived experience. What does that look like? What is your plan for that? What is your targeted programme? Who is the group you want to work with? Is there something more to find the people who aren't in your data? What is the actual intervention, your social prescribing approach? And then how do you know it makes a difference? And then the last slide, which I'll just leave with you, there's a short film there about lived experience. So what does this look like from both a practice, but more importantly, an individual's, a patient's perspective, if we do things differently and work proactively with people in the settings where they live their lives. And I know I speak fast, so apologies. And I'll hand back to you, Hina.
Thank you so much, Michelle, for that amazing overview and whistle-stop tour about the proactive social prescribing spec and really highlighting the work that's going on. What really stood out for me is, you know, it's not, sometimes it might feel like it's just another additional spec to add to the work, but actually it builds on work that's already ongoing, and just thinking about what we can do with all those connections that we've already made and the work that's already happened, especially over the last two years in the pandemic. So thank you so much for that reminder, for going through all of that. I speak fast as well, but you were really, really coherent and explained things so well. So thank you. If anyone has any questions, I know you've got to leave at 12:30. Please do pop them in the chat and we'll pick them up. A question that I wanted to ask is, you know, for those PCNs that are really starting off right at the beginning and thinking about how they can, you know, implement this spec, what would be your tip for the first thing that you think they could be doing?
Great question. And if I was at the very start of the journey, it's a bit what I said earlier, how you start will impact how you go on. If you haven't, you know, the place to start is having that shared plan for social prescribing. If you bring your community in with that, if you're working with your voluntary sector, if you're working with your local authority, public health, fire, ambulance, bleed, whoever it is, and every neighbourhood is different, you know, your community partners in that, and start small if you need to, but absolutely make sure fundamentally the voluntary sector is involved in that. You know, I could share so many examples. You know, some of you may be familiar with a doctor called Mark Spencer. You'll have your own London examples, you know, Bromley by Bow, Dan, Liana, you know, the difference that it makes. So if you don't start anywhere else, start with the shared plan for social prescribing and bring some new people into the conversation.
Great, thank you so much. So that answers one of the questions that popped up in the chat, and the other one is, how will this be monitored that the PCN has met the DES requirements?
Yeah, so absolutely what we're looking at, this isn't a performance, this is an improvement tool. So if we look at like the core 20+5 as an approach, this is an approach, you know, this is about actually trying to do things differently. So we see the role as more about how we support PCNs to implement this, rather than say, well, you've got to have done this by then, and you know, we're going to use this to measure with you. We know that we've got incomplete metrics at the moment, so we are on a journey. We're at the start of this, and we see the approach as very much being an enabler. This is an enabler. The more that we can support general practice, and we know that actually working at the point where inequality is the hardest is where general practice is also hardest as well. So we're on a journey. We're not looking to performance manage, as it were. We're looking to support improvement.
Thank you so much, and thank you once again for being with us. I know you've got to leave, and sharing all your expertise and experience with us, and for taking the questions as well. Thank you so much. If we could just go to the next slide, please. So just Michelle already spoke about some of the context within which the new DES spec is being brought about, but just a reminder around population health and the health inequalities DES specs as well, and the ICS formation that will be self-approved in July. So thinking about how the proactive social prescribing also fits in with that. Next slide, please. So we heard a few examples from Michelle, but we've got a local example from Brompton PCN, and I know that Calvant is here with us, who will be speaking about her experience of setting up a proactive social prescribing service in where she works. So Calvant, thank you so much for joining us.
Hi, welcome everyone, and good afternoon. It's a nice and hot sunny day, and we're in a webinar, which is all good. So just to introduce myself, so I work for North West London Clinical Commissioning Groups, the Integrated Care System, and previously I worked in the West Borough that covered Kensington, Chelsea and North Westminster, led on social prescribing and self-care, specifically for the borough, but also for North Kensington recovery for Grenfell impacted communities. And my current role is around personalisation, so the personalised care agenda for the whole of the ICS. And this is one of the examples that we've come across, and I've been supporting one of the PCNs within one of our boroughs around proactive social prescribing. And Econom, who's the social prescribing link worker, is actually on the webinar as well. So Econom, please do add anything that I may have missed or any of your current existing experiences today. But just to put it in a bit of, yeah, thank you. Just to put in a bit of context, our North West London approach to social prescribing and self-care and the whole agenda is very much similar to what our previous speaker spoke about. Is around a collaborative approach and being enabling to make sure that it's everybody's business, and to put the patient carer at the heart of the care, and also to ensure that we look at what matters most, hence why we need to look at this very differently from what we usually do. So within Brompton PCN, which is, as I said, was Kensington Chelsea Borough, we're really fortunate in the sense that we have a very vibrant, well-resourced voluntary community sector, and we've had long established relationships with that sector, and they've been commissioned directly by by health in the past and currently as well. So I think that goes a long way. But having said that, boroughs that don't have those relationships, or maybe not have as much resource, can still build and forge those relationships, because at the end of the day, we're all working towards the same population group, and we're all trying to support that same population individuals and have that holistic approach. So within Brompton, it was clearly identified that they wanted to build upon existing work that had happened in the wider system, but also identified a particular gap. And it was very much around looking at, rather than doing case finding within their existing patient population, that maybe patients that already present themselves and use primary care quite well, are well versed in it. It was around looking at how to work differently and addressing those true health inequalities within that PCN geographical area, and looking at those individuals that we don't hear from. So I don't like to call them hidden or seldom heard, is because we don't actually go out to proactively hear from them. So this is very much an inward facing sort of like service, where the link workers will be proactively going out into the community where people gather and meet in order to talk about primary care, have a look at what their needs are, and then to do those social prescribing referrals. So this particular service is very much around looking at the fuel poverty crisis and the cost of living issue as well. So working quite closely with a number of food banks that are within that geographical area, working in partnership with the food banks to set up a regular drop-in service where the link workers would be there at the food bank days, so they could informally talk to people, talk about what they can offer, and also build up that trust and relationship. So it wouldn't be something that they would go into on day one and start taking referrals. It's very much about being seen, heard, and explain what they do. In order to do this, it was very much around bringing a short sort of task and finish group together, and it's really important that you had the right people within the system to enable this. So it's very much around, we had a clinical lead for social prescribing for the PCN. We had our link workers obviously at the forefront of this, as well as the local authority that led on some of the food bank work. And in addition, working with our local One News service that can offer the opportunistic health blood pressure checks. Having done loads of outreach in my historical working life, blood pressure checks seem to really attract individuals, and it breaks down a barrier for people to actually talk to somebody. So that was really an opening chance. And also it looks at the core 20+5 as well, around looking at maybe individuals that may be displaying high blood pressure but don't have the opportunity or don't have the resource or don't have the time to go to their GP to talk about these things, but they could be picked up there as well. In terms of how this will happen and what will be happening, so as a summary, they'll be looking at that improving access to primary care, but also tackling any issues around unregistered population, be able to support people to register if they're not registered within primary care as well. Also, it will be looking at identifying those people that may necessarily be walking around with high blood pressure. That's a very high clinical risk. So again, being able to support those individuals getting the right services, and addressing those sort of like cost of living crises, and really looking at the heart of the core of the issue around what matters most to that individual. And so it's sort of like a wraparound service. Now, currently, with the stages, the negotiations have happened with the food banks, and the link workers will be start operating, and it will be very much a sort of like test and learn type work, and to reiterate and tweak the service as it goes along. Eknam, would you like to add anything, or have I missed anything?
No, you haven't missed anything. Really, you've pretty much covered it. I think the focus for us is with the blood pressure checks, and also trying to make sure that we register people. My understanding from the lady we spoke with today is that a lot of them don't have home addresses, but they all register with one homeless shelter like the Methodist Church or somewhere else. And even some of them in temporary accommodation also do not like to use that address. So it's just to now try and find a way that we can get them to register with the GP surgery in the first instance, and then take it from there. It won't happen in a week, it'll take a while, but it's a beginning.
So I think that just shows the example of this is going to be a really true sort of like proactive way of doing social prescribing, going to the heart of the community and talking to those population groups that we really do not engage with very well. So it'd be really interesting to see maybe in another 3 months where what sort of like the outcomes we'll be seeing.
Thanks so much, Calvin, for giving that overview of some really inspiring work that you're doing in North Kensington, it's close to where I work, and really bringing home the message of how proactive social prescribing can actually work in practice, and your experience obviously of all that outreach work and what works as a hook. It's clearly been really helpful. Any questions for Calvin, then please feel free to put them in the chat. I just wanted to ask a question, just following on from the last point that you made around reviewing it in 3 months. Do you have any idea about what kind of things you'll be looking at to see whether this is working?
So I think the key things will be around the level of engagement of the individuals that actually attend a food bank. So is it something that they found useful? Is it something that they just don't want to talk about? Also, it'll be looking at some sort of like key demographical information in terms of how many people were the link workers able to engage with, what type of population were they, male, female, what age ranges, what were the types of health conditions, and as Econom rightly pointed out, what are the types of key themes that are coming up? Is it very much around unregistered population, homelessness status, or is it around individuals that do have a GP but choose not to go to a GP, and what's the reason? And it'd be really interesting to see how many people then make a sort of like a more long-term relationship with the link worker because they need a specific issue addressed that are from that particular PCN. And also we've got a mechanism where if an individual is presenting at the food bank but registered with another PCN outside of the area, they'll be able to make an onward referral as well to make sure that a person isn't left without a service.
Thank you so much. Thank you once again for coming on the call and for presenting your work, and thank you, Econom, as well, for all the work that you're doing as well. And it's really nice to see how close, you know, how the role of link work and really helping to identify those cohorts of patients who have unmet needs, who might not be presenting to GP services and are getting left behind. So some really important work that's happening there. Thank you so much. Jenny, if I could just ask you to move to the next slide, please. So we're building a map of some examples of practice social prescribing that's taking place in London. This is a snapshot. So, you know, if you would like to contribute to this, you know, and if you're doing any work around this, then please do get in touch with us. It doesn't have to be a full in-depth case study. You know, it could just be a brief description of the work that you're doing. And Jenny or Liana, if you could just pop the email address for getting in touch if colleagues would like to contribute to this map, then that would be great. Thank you. Next slide, please. So I know we've had a lot of really inspiring examples across the system nationally and also more locally in London about the kind of things that, you know, that PCNs are doing. So maybe just to bring this together and to think about what this could mean to you and what the next steps look like for you. You know, things that have already come out include thinking about, you know, who had stake in this work, who would you rally together for this work in your PCN, your wider allies as well, looking at mapping the assets as a group, you know, what people, resources, meeting, data networks, anchor VCSCs can you engage with that are already present or that you know that you may already have a relationship with, thinking about who can do what. Can you set up a working group? In Calvin's example, there's a task and finish group that was set up. Can you design leads for these areas, lived experience, population health and inequality data, social prescribing data? And thinking about how you could brainstorm ways to access, analyze and draw insights from these three information sources. So, for example, of analysis of social prescribing access data that Calvin mentioned they'll be looking at, doing a local needs assessment, lived experience mapping as well. And something to think about. Next slide, please. So now it's over to you. So we'll be putting you into breakout rooms to discuss amongst yourself what some of the next steps could look like for you based on what you've heard already and the previous slide as well. So, you know, you may want to think about your stakeholders, who your assets are, what the practical next steps may be that you can take, and what support regionally would be useful for you to make this happen. So we'll give you about 20 minutes or so, and it's really a space for you to kind of, you know, discuss with other colleagues and really think about how you could put some of the information that you've heard already into action. Okay, great. Well, we hope you found that that useful. It'd be really good to just go around the groups and hear some of the discussion points that came up. And maybe if we could just look at each of the different questions that we asked you to think about and see what, you know, what kind of discussion we've had. So thinking about your stakeholders and who might help you in delivering work around proactive social prescribing in your PCNs. Any thoughts about who you could reach out to? What came up in your groups? Anyone?
Khadijah's got her hand up, by the way.
Oh, sorry, I can't see hands. So if anyone does, if you just let me know, because I can't see
Yeah.
them. Khadijah.
Hi everyone, can you hear me? Yeah. Yes, so for us in Hounslow, like myself and Katie and Ella were discussing, my colleague, she's here as well, Cheryl, we already have something happening in a PCN, looking at a cohort of patients with respiratory difficulties. So so there's a group in Hounslow called Respiratory Group, and my colleague here has been working closely with them for her PCN. So for me, it's the selling point to convince the two PCNs that I'm working with, because some of them usually are on the fence when there is no money involved. The clinical directors are always on the fence to engage with new things. So I think the selling point for us would be, look, this is needed, this is required for us to do, and we already have a PCN that is piloting it to generate referrals, but we can also concentrate on using this as what's been required. I think for us, what we discussed, Katie, was in terms of support to get from the region would be if there is a document stating out what the requirements in a structured way, most of them will buy into it. Also in Hounslow, we have a workshop, like a think tank group coming up in July. We're collaborating with the council and the mental health team. I think they're called Means team. So we're having a collaboration with them. And for me, I'm already thinking of how to discuss, you know, we getting this done in terms of finding venues. The council is already on the board to host us for meetings and workshops. So it's something we could go forward with, but we would need the support from the region in terms of having a structured document for us to show the clinical directors, because from experience, they need to see black and white to buy into things sometimes, and it would be a good selling point for us. But it's something I am really excited about, because I've got a selling point to go back to them to convince them to let us do this. Thank you.
Thanks so much, Khadijah. I really like that idea of that think tank where you're bringing together lots of different sectors in your community, from, you know, councils and various other organisations, to really come together and work collaboratively. So from a stakeholder engagement perspective, that sounds like it might be really helpful. So thank you so much for sharing that. Katie, you've got your hand up.
Two things really. So I was really interested in hearing what you're saying, Sarosh. In our PCN, the social prescribers do call the patients who have the repeat fit notes. So what you were saying there makes me think that could be our project too. So that is brilliant, hearing what you're doing. But the other thing I did want to ask is, ideally, in terms of the stakeholders, I'm thinking, should we be looking to do these as cross-borough projects, or should we do so individually as PCNs? Because we've begun work on the health inequalities project. So in Newham, we're doing this across the borough there's one topic, one main topic right across the borough, but then each PCN is doing a local project as well. So what's the advice really on that? Should we just extend what we're doing for the health inequalities project, or should we actually be better off focusing on a different topic?
Thanks so much for that question. Was that addressed to any particular person or generally?
No, just anyone really.
Just anyone
who could give us that advice on what we should do next.
Yeah. I mean, if anyone is already working on this or kind of doing cross-borough work, then please do put your hand up. But there isn't any kind of hard and fast rule, and each PCN and borough is kind of looking at what works for them. So you may find that, so what we're finding, for example, is that a PCN, you know, in this case, for example, when we presented Brompton's work, they're working on a PCN level, but there are also in other areas of London and across the country, I'm sure, groups of PCNs working together. So the neighbourhood model as well, and then in other areas, you know, they've come together on a borough level. So I'm thinking of one in southwest London, but I can't remember the exact borough. But there's no one size fits all approach is the main thing, and it's what works for you. So if on a borough level you're already having kind of health inequalities work that's happening, it might be worth thinking about how you as a PCN or a group of PCNs could fit in with that. And it may be that you have those conversations with them. So it's not about it's not about working in silos. It's thinking about how you could be working together and kind of adding to each other's work. But if anyone else has any comments, then please feel free to share.
Dan will know this well from the Bromley by Bow Centre, but quite often voluntary sector organisations will be convened by where there are them umbrella bodies, and sometimes it can be really helpful. I think one of the things when you're doing the scoping for this piece of work, it sounds like you guys are a bit further ahead, is to know what meetings are already happening, where are those groups already being brought together. And it does make sense post-COVID. During COVID we saw a lot of multi-sector representatives coming together to think about how to stand up emergency services at a time when everything was very different. And so there will be a bit of a some of those relationships will exist at a borough level, and it makes sense if those meetings are already happening to join those meetings and to get a bit of an understanding about what the priorities across the borough are. However, there will be some PCNs that are in areas of particular deprivation. There might be, specific postcodes. Going to your, using those meetings to find out who your local authority public health representative is, approaching them and understanding which postcodes in your primary care network have a high risk of people falling into rent arrears or council tax arrears, will give you really valuable data to overlay on those that maybe have a mental health issue and a long-term health condition. Take those three things and you've got a really nice, not obviously more consultation needs to happen than that, but that could be a nice way of thinking about who you, with your health inequalities leads, your public health person, perhaps an anchor voluntary sector organisation that is very prevalent in supporting people coming through the referrals in your PCN. Perhaps all could be agreed that could be an interesting way of looking at kind of what proactive social prescribing in your primary, how you can localise what is already happening at a borough level. I don't know if that's helpful, a helpful addition to what Hina's talking about.
Yes, definitely.
Dan, how did Bromley by Bow navigate that issue of sort of borough versus PCN?
I think we're very focused on PCN actually, we deliver social prescribing to one PCN. Nonetheless, there are organisations that are working across borough. I think often the more specialist ones, and it's really important to liaise with those. What we have established in Tower Hamlets are a series of breakfasts. We have 3 postcoded breakfasts, London E3, London E1 and London E2, to which frontline staff are invited. And these attract anything up to, I spoke at the last one and there were about 40 or 50 organisations there. These happen every quarter. I think probably actually they should happen maybe every 2 months, a bit more frequently. But this absolutely allows social prescribing link workers who convene the breakfasts to interface with a wide range of voluntary sector and statutory partners actually within the borough. And it allows the organisations that are seeking, they've got specialist skills or specialist constituencies that they support, to go to all of those breakfasts so that they're able to kind of have that reach across the whole borough. But it also allows a focus that's a bit more geographic as well. I think it's combining the two really. You know, you think about homeless charity, for example, they're serving often a much wider geography, whereas you think about a small neighbourhood group, they're serving maybe, you know, 2 or 3 housing estates and not even a whole PCN necessarily. I think one has to work with all of those levels of scale. But what also, of course, those sorts of breakfasts allow is for those organisations to network with each other. So it's not just about forging stronger links for the link workers. It's about all of those organisations forging stronger links with each other as well. I hope that makes some sense.
Thanks so much, Dan. I hope that was helpful, Katie. And in the last couple of discussions, I've covered the first 2 points, so stakeholder engagement, and also thinking about assets as well, and you know, across communities, across levels, what work is already going on, and you know, essentially more joined up care and support. There have been a few questions in the chat as well around funding. I know, and Khadija, you mentioned about what regional support you would like in terms of taking to your, you know, the CDs of your PCN, some concrete things about what could, you know, what proactive social prescribing looks like. I mean, there is some, I don't know whether you've had a chance to look at the DES spec. It is, you know, it's one of those things, because it's about having a localized, tailored approach. It's not very prescriptive. It is according to what the PCN's needs are. And, you know, hopefully you've had some ideas today of how you could identify the local needs in your PCN and take them back to your CD and present a case for that proactive social prescribing work to take place. Just in the interest of time, because you've got 5 minutes left, I'm just going to pick up the one question and ask Leanna to answer, because I know you're probably best placed to answer that, and that's about funding for VCSE organisations. So there are a few questions about funding. One of the barriers we face is VCSEs asking about funding. So, you know, where can they access funding from if they want, you know, if they're going to be engaged in this work to develop that proactive social prescribing alongside primary care?
So there's a couple of answers here. Some of the I've put an answer in the chat, but some of the CCGs really see the value in investing in the voluntary sector, not all. We currently, HRP have got a project to pilot a cross ICS approach, where there will be pots of money at a borough level that health are putting money into and local authority are putting money into. There is a hope that will be rolled out across London. In some places, in some areas of the country, the NHS commissioners have committed to 1% of the NHS budget, or at least trying to work towards committing 1% of the NHS budget to voluntary sector organisations. However, everybody is being asked to cut costs right now. Everybody is being asked to justify every penny that they're spending, and it will be a long-term influencing piece. So I'm by no means counting our chickens on that front. And your PC, you know, some PCNs have found money within their budget somewhere to fund small projects or put money alongside social prescribing. And perhaps they've got that out of their CCG by going to them and saying, we've got this really great idea, this is what we want to do, this is a massive gap, and we think if we invest in these services, it's going to save us X amount in the future. So PCNs can, you know, can have those conversations with their CCGs and their commissioners. But it does require some proactive work, and perhaps that's something that you and your health inequalities lead can be approaching commissioners both in the health service and in local authorities with. And one of the things I was going to say, because there was some really good chat we were building in our breakout room, we were building a really good list of the allies to this work, the stakeholders in this work who could be really helpful in undertaking this work, and then what are some of the resources, assets that people have or feel that they might want and need from a regional support offer. So I don't know whether or not it's if other people did follow the exercise in the same way, if there's any chance you could take a photo of your notes or forward them to us so we can collate them and add them to the slide, so that when we circulate the information from today's session, we've got a good crowdsource of all the things that people have been discussing in their breakout rooms. Is that so? Jenny's just popped the email in the chat. I don't know if anybody else has sort of taken some notes that they might be willing to share, because I think this is the first step, is like talking to you guys and getting an idea about what's some of the things that you're utilising and finding useful in your local systems, and sort of almost pulling that together in a regional resource.
Thanks so much. So if anyone has taken any photos or have got any, written it somewhere on a document, and if you could share that with us, and Jenny's put her email address, that would be really useful. There was a lot of rich discussion that came out in the conversation, so we didn't follow the feedback specifically around the 4 questions, and time is always feels that it's against us. So yeah, if you could share anything, that would be great. We've just got a few final slides. It's mainly just a list of key resources to share with you. Jenny, if I could ask you to just put the slides up again, that would be great. Thank you. So some other key enablers to think about, which we've already discussed, your other R's workforce, the care coordinators, health and wellbeing coaches, spoken about ring-fencing time for community development for link workers, and looking at link worker caseloads as well. So do they have capacity for proactively identifying people to work with and fit these in? So some thoughts for you to take away as well as you think about developing strategy for your PCN. Next slide, please. So this is a session that we held in response to some of the challenges that we've been hearing from you. Doing this at a pan-London level means that we're in a place where we can share best practice, discuss challenges and work through them in partnership, and develop a collective understanding of what can be achieved. So moving forward, we'd be really interested in hearing what your thoughts and suggestions are around what other sessions could look like, or what would be helpful for you, because that's what we're interested in making sure that these sessions are useful for you and the work that you're doing. So continuing the conversation around the personalised care desk spec, are there any things is there anything that you think would be useful to cover at another session because we didn't cover it today, for whatever reason, time, etc. Would it be useful for you to come together to discuss common challenges that you're facing in your PCN? So common ones that come up are things like recruitment and retention, funding, supervision, evaluating impact is another area that often features. So you can pop the suggestions in the chat or email us as well, because we'd really like these sessions to be shaped around what you think would be most useful. And in future, thinking about also breaking down the workforce development framework as well. They are currently in draft circulation, but will be published shortly. So, we could perhaps looking at having a session on that as well, if that would be useful. So please do let us know. Next slide, please. And these are just a couple of slides at the end around where you can access further support. The slides will be shared with you for you to reference after the event today. Also a reminder that you can join our WhatsApp group as well to continue the conversations offline. There's the Futures NHS platform as well. And feel free to reach out to us on email if anything comes up for you that you'd like to share with us. So thank you so much. I'm really sorry we're a couple of minutes over time and we didn't get to cover everything in detail, but thank you so much for coming to the session today and for sharing your feedback and contributing and coming up with some really great ideas around the next steps for you. And hopefully we'll see you at the next one. Thank you.